Thank you very much, all the audience coming for this session, and welcome all the audience online as well. And we have a very exciting session on dual antiplatelet therapy. We will be discussing some interesting aspects of dual antiplatelet therapy, this indication. And to start with, we have our distinguished speaker, Professor Fawad Farooq, who is a professor at the National Institute of Cardiovascular Disease. So, Fawad Farooq, can you present your slides, please?
Thank you, Mehmood, for the introduction, and thanks to ESC for the first time they had given us this opportunity to have our highlight session. We actually had two talks in this session, but unfortunately second of our speakers not here. So what we'll do, we'll try to cover this topic and take input of the audience as well as discussion to cover. We have 45 minutes whole to discuss it all. Our second topic was device therapies in heart failure, but unfortunately there may be some emergency with Dr. Ghazala, so she hasn't turned up. Now regarding antiplatelet therapy, we all know that now we have multiple antithrombotic available to offer to our patient at different stages of coronary artery disease, starting from probable ACS to stable IHD. So it's very important to identify at which stage of disease, which kind of drug to be offered to our patients. The spectrum is so wide that primary prevention, in secondary we have to offer it in non-ST, unstable angina, STEMIs, peristenting period, and others as well. And along with antithrombotic, a lot of our patients may need anticoagulant as well, to how to manage all these together. Just starting with the background, we know the disease starts from phases: atherosclerotic disease like lipid deposition, inflammation, and leading ultimate thrombosis, which bring your patient to the event as like different categories. Either it's involving brain, then you can have stroke, heart, then non-ST and ST elevation, MI. If patient haven't had any thrombotic event, they continue with the disease and may present with progressive chronic symptoms. So in whole, the whole disease presents as two phases: atherosclerosis and atherothrombosis. The management of atherothrombosis is altogether different from that of stable plaque atherosclerotic heart disease. That we need to understand to pick our patient early for developing thrombotic events or a precursor of that, the warning symptoms, and then offer them timely the antithrombotics. We know this is the timeline starting, but that thrombosis can happen at any stage of disease, not just at like 70-80% of the disease stenosis. Phases, we all know that endothelial damage, plaque rupture, sequence of events, platelet-related adhesion, activation, and ultimately aggregation, which leads to clot formation, and platelets are playing the major role in those all like phase. And we know that now we have almost 3-4 kind of antiplatelets apart from aspirin. Aspirin, the gold standard, is there, but along with it we are using P2Y12 inhibitor, clopidogrel, ticagrelor, prasugrel, and now even cangrelor. Then we have antithrombotic along with it. Overall, everything is really taking care of this whole thrombosis cascade at different stages. But today we are focusing on antiplatelets. So let's just quickly go through the latest guideline recommendation from European Society of Cardiology, that how we have to really apply them. Aspirin, we all know, 150-300 orally, and then 75 to 250 milligram if oral ingestion is not possible, with maintenance dose 75 to 100 milligram. That's the part of aspirin. Then clopidogrel, the loadings is 300 to 600, with maintenance of 75. No dose adjustment is needed in CKD patient. If offering fibrinolysis, then at the time of fibrinolysis, its initial dose should be 300 milligram, and if your patient's age is greater than 75 milligram, with thrombolysis, it should be given 75 milligrams. A few things need to be remembered, especially if you're offering thrombolysis, that 300 milligram loading dose if age less than 75 and more than 75, there's no need to give 300 loading, it's just 75 with start with. Prasugrel loading 60 milligram followed by maintenance dose of 10 milligram in patient with body weight 60 kg, or maintenance dose should be. So if you have a lesser weight of your patient, then the maintenance should be 5 milligram OD. In patient age greater than 75, prasugrel should be used with cautious, but a maintenance of 5 milligram should be used if treatment is deemed necessary. So in old age patient, again, these are the two. And if patient had a prior stroke, then you can't offer prasugrel. So there are three limitations when you're using prasugrel. Maintenance is 60, but your patient has lesser weight and is old age, more than 75, and weight less than 60, then you have to offer half the normal maintenance dose. This is 5 milligram, and any prior stroke, and you can't offer prasugrel to these patients. Absolute contraindication. Now, ticagrelor loading dose 180 milligram followed by maintenance of 90 milligram BD. No dose adjustment is needed in CKD patient. Ticagrelor, although not used in our setups, but it's bolus 30 microgram per kg IV followed by 4 microgram per kg per minute infusion for at least 2 hours, or the duration of procedure, and whichever is longer, you have to continue with it. In the transition from cangrelor to thienopyridine, thienopyridine should be administered immediately after discontinuation of cangrelor with a loading 600 milligram clopidogrel, 60 milligram prasugrel to avoid a potential drug-drug interaction. Prasugrel may also be administered 3 minutes before the cangrelor infusion is stopped. Ticagrelor 180 milligram should be administered at the time of PCI to minimize the potential gap in platelet inhibition phase. So these are the various methods of like loading your patient, transition from cangrelor to IV to oral antiplatelet. Now we move on to how to incorporate them along with other antithrombotic in your offering acute management strategy and how to continue with them for a longer period of time according to the patient's status. Like STEMI, we all know that primary PCI, the antithrombotic unfractionated heparin or enoxaparin, biliverdin, but fendoparinox we can't offer as adjunct to intervention. For management of antithrombosis, conservatively without intervention, yes, you can use fendoparinox, but it can't be used as an adjunct to intervention. Then routine antiplatelet aspirin as a class 1, then P2Y12 and non-ST-ACS class 3 routine. That's a key point, that giving P2Y12 inhibitor to every non-ST-ACS patient is now class 3. You have to identify which patient at which dose and which drug, and then subsequently planning accordingly, like the patient's clinical characteristics or time of intervention, or you are managing delayed intervention, early or immediate. According to that, you have to offer the P2Y12 inhibitor. It isn't a routine drug to be offered to every patient, but it's to be in the situations where you think you have delayed intervention, you can offer a P2Y12. But routine giving aspirin and P2Y12 to every patient with non-STS is not on. In STEMI, you can give. Then invasive coronary angiogram, ACS, prasugrel, ticagrelor should be preferable over the clopidogrel. If they're not available, then certainly you can go on with clopidogrel. Proceeding to PCI, you're sure that you're doing PCI in your patient's clinical characteristics or patient's young age, you think that you are, or you have seen the anatomy and going for PCI, then prasugrel should be preferred over ticagrelor in such patients. So you're straight away, after taking a patient going for intervention, then along with aspirin, prasugrel would be preferable drug. So a combination aspirin plus P2 vital inhibitor starting in an ACS patient up to 12 months is the standard. And after that, aspirin, and according to the patient thrombotic and bleeding risk, you'll decide what to do next. In that sense, alternative strategies for high bleeding risk patients. Here you can manage your antiplatelets duration accordingly. You should be starting 0 with like depth, de-escalation strategy that you're starting with like aspirin or prasugrel or aspirin with ticagrelor. So after 1 month, you can de-escalate to a lesser potent agent like clopidogrel and then continue with aspirin and clopidogrel for further like duration of 6 months or in 12 months according to the patient thrombotic status like background of ACS or stable IHD, and with that you can decide accordingly. So you can de-escalate in high bleeding risk patient. And the third part of this antiplatelet strategy is very important when you need an antithrombotic, a chronic anticoagulant with your patient. In that, you have different strategies you can offer to your patient, like triple antithrombotic, NOACs or DEPT. You have to start with certainly, if you have a background of like atrial fibrillation or any other condition where you need an anticoagulant which is needed for prolonged period of time, you start with your dual antiplatelet, either aspirin, clopidogrel, or some even ticagrelor. Preferably clopidogrel would be a good choice when you're using triple antiplatelet, triple antithrombotic. So NOAC and DEPT, class 1. In the default or conventional strategy, you should be offering these 3 drugs for a month. And after 1 month, you have to switch on to your anticoagulant, meaning by dual antithrombotic, in a way that NOAC and single antiplatelet, which preferably would be, here you can switch on even ticagrelor can be used, but if you're starting with triple with clopidogrel, you can continue with clopidogrel and your lower anticoagulant as well. But in a very strategy to reduce ischemia risk, you can continue it with for 4 months. In patients with high bleeding risk, you can give it for just 1 week and then continue with dual antithrombotic like NOAC and your single antiplatelet for 6 months. Then accordingly, you can continue it for 1 year, or you can switch to NOAC as a monotherapy. And after 1 year of treatment, there is no need of antiplatelet. You can continue with your NOAC as both like antiplatelet or antithrombotic coverage. That's important. We are still seeing a lot of patients on antiplatelet plus NOAC as well. Once your patient has passed that 1 year period of time, then you can stop your antiplatelet and just continue with, when you're giving a full dose of NOAC, that would be enough to cover them for both reasons, for anticoagulant as well as antiplatelet. Unless and until they have some new event, then you can continue with again dual antiplatelet with same strategy. So in this strategy, the triple antithrombotic, we have to use either 1 week or 1 month, depending on the patient's bleeding risk. If high risk, just 1 week, and then switching on to dual antithrombotic, antiplatelet and anticoagulant, and preferably P2 vital aspirin you can take off, clopidogrel or ticagrelor and your antithrombotic, and then for 6 months or 1 year, and then continue with your antithrombotic subsequently. With that, I end my presentation, then it's open for discussion. Thank you for your patience listening.
Thank you very much, Dr. Fawad Farooq, for a nice presentation. Dr. Professor Sial, what do you think? What is your practice of the dual antiplatelet therapy in patients with acute coronary syndrome?
Thank you very much. I think I'm audible to all of you. Before I comment on your question, I must say I must appreciate attendance of my fellows from Pakistan and from other areas. This is the first time European Society of Cardiology has given opportunity to Pakistan Cardiac Society on this global stage. So this is a great honor, and I'm thankful of all of you that you are part of this whole success, and this success will move on from here onwards. Coming to your question, because this is still there is a bit controversy, controversy still there that how long you can continue this DAPT. There's no doubt about it. The efficacy of DAPT is very much now, because in the era of probably 20 years back, when only this ticlopidine was used for only 15 days, there are a lot of issues with the stents. Then this drug, clopidogrel, come, and other clopidogrel sister compounds come, they revolutionize the changes, and now there is very less frequency of stent thrombosis with this. But still there is controversy. Few people like it to continue for 1 year, and some prefer it to continue it for 3 years. And we, as Professor Fawad Farooq told, there are different efficacies of different class. Now ticagrelor is being used widely, especially in patients with who present with ACS. So, but there are certain problems which at least I am feeling in my practice, that a lot of patients come with shortness of breath despite having normal echo, normal hemoglobin. Probably that's a problem where we discontinue this drug. And certainly there's the cost is again an issue, because this compound is being used BID and probably much more expensive than clopidogrel.
Thank you very much. One important issue is the patient using dual antiplatelet therapy, that we judge the patient as such, and then there are another sets of patients who are at high risk of bleeding. So what do you think, Dr. Fawad, what should be the strategy for this patient?
I think whenever you have a situation where you have to weigh the risk and benefits, so it's bleeding risk, then you have to elaborative enough what kind of bleeding risk they have. Even in bleeding, we have different kind of classification, minor, major bleeding, even risk scores are there. So you really identify their exact bleeding risk according to those scores and their background risk. And then weigh the thrombotic risk, what you are dealing with, whether conservatively or invasively, and in invasive strategy, then you really make out your invasive strategy according to the bleeding risk. Sometimes even in PCIs, we don't put in a stent in a patient who's having enormous bleeding risk. We just balloon or put in a bare metal stenting. So it's all depend on patient to patient, his overall bleeding and ischemic risk, and this then decide accordingly. And nowadays we have multiple lotions, as now I've shown you, that you can make different strategy, picking up different drugs at different dosages with different timings as well accordingly. And there are newer studies coming up in relation to stents as well, polymer-free stents, where you need very, you can say, a shorter duration of depth, even sometimes 1 month is being tested as well. So you can continue with just 1 month of depth and then single antiplatelet with either of the P2, Y12 inhibitor. So it's all depend on bleeding and ischemic risk to decide according to your patient. So one really shoes doesn't fit in for everything. That's my answer to that.
Thank you. One of the important...
Mike.
bleeding, the guideline recommend probably 2 or 3 strategies with which you can reduce the ischemic events, and at the same time you should reduce the risk of bleeding. One strategy, you should take the strategy of shorter duration. That shorter duration mean what they have defined it as 1 to 3 months. One thing, for those who have at high risk. Second, you should use prasugrel or ticagrelor rather than clopidogrel with aspirin. That will reduce your risk of bleeding, but that should be kept for a short duration, and after 3 months, 1 to 3 months, you should continue with single antiplatelet. My question would be, the usual scenario which we are facing, that is the patient who are referred, who are presenting to a non-PCI center where they are thrombolized and they are referred for pharmacoinvasive therapy to a PCI capable center. So my question would be from Dr. Fawad, what is the guideline recommend about the P2Y12 strategy with dual antiplatelet therapy, and which should be used, and what should be the doses, or they are not should be given at all when in the patient who are thrombolized in the periphery. You are kind.
Yeah, you must have seen in the latest guidelines, they are it's a very high thresholds to use GB2B3A inhibitor nowadays, because now even you have an IV P2Y12 inhibitors. So the only reasons now left is that's usually we use P2Y12 after intervention, seeing a very, very high thrombotic burden, no reflow state, or pre-procedures very rare, very, very rare. Most of the guidelines are now either 2B or even 3 for using P2Y12 as your pre-procedure strategy. Now, the scenario which you build as a case who's already thrombolized and now referred for pharmaco-invasive therapy. In these patients, usually they are preloaded with antiplatelet. As I discussed, that their loading would be slightly different, that they should be loaded with 300 of clopidogrel if they are less than 75 years of age. If they are more than 75, then you need no clopidogrel at that particular moment. Now it depends, do you want to continue with clopidogrel or want to switch them from clopidogrel to ticagrelor? In a way, you said usually it's seen that clopidogrel is slightly lesser potent as compared to ticagrelor. Ticagrelor has slightly more bleeding risk as compared, but with good potency as well. So it's all depends. Certainly, if you've got a patient who has thrombolized just 4 hours back, I would continue with clopidogrel in that particular patient, and then see subsequently, because his internal melia already is very high risk for bleeding because of the effects of those thrombolytic, which continue with at least 12-24 hours. So, but it's all subjective. You have liberty to use whatever strategy you think, because if you think your patient is high bleeding, along with it he's having very high thrombotic risk, and you need a very potent antiplatelet, then you can use ticagrelor, again loading 180 and maintenance of 90 without any. Prasugrel is a bit tricky in this situation. Patient with high risk of bleeding, even if they're qualifying with that preconditions, it's a very high risk in that situation using prasugrel, although you're going straight away for PCI with the background of thrombolysis. That's my personal opinion, considering all the things together. So I would continue with either clopidogrel as such, or unless and until I'm doing a very complex kind of procedure after seeing the anatomy. But most of the time you can give it after seeing anatomy of the patient, that what antiplatelet you will. So that's why now having multiple antiplatelets, you can plan strategy according to the key things are to think of the bleeding and thrombotic risk. and decide about it?
Clopidogrel is less potent, or you can say there is a resistance is developing against clopidogrel. So I think it's not potency, but we all know that this drug is actively being used for last 15 years. So probably there is a drug resistance, and that has been documented in different studies. And regarding prasugrel, I think it's very effective, and you might know that probably more than 20 companies have given license approximately 12 years before in Pakistan, this prasugrel, which is effective in a way the only in patient where early invasive and patient who has primary angioplasty done. But unfortunately at that time company was not encouraged, because at that time there are not lot of ACS angioplasties were being performed in Pakistan. So it has been wiped out from the market. But I think it's still, if you remember, there are 2-3 contraindications of prasugrel that can be a good alternate where the drug resistance with clopidogrel is. And there are certain studies, even our institute was part of that ultimate DAPT trial, probably that is being published in near future, where this DAPT is used for 1 month. It's a double-blind trial, and this is a multinational. Chen was a principal investigator who invented this DK crush. So NICVD was part of that ultimate DAPT trial where clopidogrel or DAPT has been used for 1 month. Let's see till these results came. So still this topic is very hot and controversial. We don't know exactly till when this DAPT should be continued.
I think regarding prasugrel, its indication is very limited in a way that you can't give prasugrel without seeing anatomy. That's the big issue with its left, right and center usages. Initially when it came as a generic to Pakistan, people started using without knowing its exact guideline recommendation. The guideline is recommending prasugrel only in a situation where you're going for PCI and you have seen the anatomy and you're doing PCI. You can't give it like in a probable kind of situation where you're dealing ACS and you can take care. So it can be given only in those centers where the immediate PCI facilities are available. That's the main reasons of not flourishing prasugrel in Pakistan as such, because we don't have that much centers that where patient can be offered PCI just after entering into the ER, immediately afterward. We have to load them with P2Y12, and usually it takes 6 hours, 12 hours, or sometimes even more than 24 hours. So that's why it's not really fitting in our setup. It should be available, but nowadays it's very difficult to find prasugrel in our part. That's the only reason, because now nobody is using it, so that's why it's not there in the market. So we have to rely on ticagrelor or clopidogrel. Any other?
Responding to, just to add to the question asked by the audience, that it is important then when you are shifting a patient to the PCI capable center, so after lytic therapy or along with the lytic pills, so don't use this prasugrel or ticagrelor. This is very important because this is the latest few studies that show, and this is included in the guidelines. So you should not use when you are sending a patient to the PCI capable center. The ESC and AHA both recommend that you should adopt a policy where you tailored the therapy and you have to make individualization for the treatment of a patient with acute coronary syndrome, so which antiplatelet therapy and how much angioplasty. Another important question is from both of you, that what should be the ideal duration of the antiplatelet therapy in different scenario of the patients?
I think what's my practice, how usually I stop DAPT after 1 year, except in few cases where at least 3-4 stents has been placed, or patient has already a complication like stent thrombosis, or where I have used long stent with small caliber like 2.5 or 2.75. Otherwise, I usually stop after 1 year.
Fawad?
Usually that happens, but sometimes you have to stop it earlier in a way, like situations where your patient needs surgery or anything of that kind, where you have to stop antiplatelet. Especially in patients with stable IHD. I've done intervention with stable IHD. You can stop them a bit earlier, even the guidelines are suggesting you can stop at 6 months. But then there is a competition between whether to continue with aspirin or clopidogrel as a single antiplatelet. And now even that low dose anticoagulant like rivaroxaban 2.5 milligram is also jumped in as a prolonged strategy. So you have that third option as well, that continue stopping your P2Y12 inhibitor and continuing with aspirin and rivaroxaban 2.5 milligram. And good patients for this kind of strategies are those who are having multi-vessel disease, a multi-territorial atherosclerotic disease, like involving brain, involving peripheral vascular disease, involving coronary artery disease. So have a multi-territorial atherosclerotic disease in a patient, then even that would be a good strategy, stopping your P2Y12 after 1 year and then continuing with aspirin and rivaroxaban low dose, and that would be beneficial to them for their long-term prevention of atherothrombotic events in all these territories.
There is emerging studies which suggest that you can use the double antiplatelet therapy 1 to 3 months and then you can stop it and then continue with the single antiplatelet therapy. While it traditional is that you use in patient with the PCI, after PCI, so you have to use it for 12 months. But now this emerging data is suggesting that you can use it for 1 to 3 months depending upon the patient scenario. So keeping in view the thrombotic events and the risk of bleeding as well. Thank you very much for this session, but since we don't have another speaker, so we have some heart failure council member in our so she just arrived. Okay.
Oh, so you have transferred your presentation?
Oh. You can meet...
That lady will help you, Ghazala. That is running. वो आ रही है इस बार.
वो स्पीकर सर्विस स्टेशन पे जाना होगा आपको.
I think time हो गया है. Probably Ghazala?
I think
time हो गया है. हमें स्टेज नहीं है. तुम अब बैठिए. No. Probably Dr. Ghazala से opinion ले लेना. Just presentation को छोड़ दे, वो खत्म करेंगे.
So we can discuss like this, no issues. So Dr. Ghazala is a professor at the National Institute of Cardiovascular Disease. Thank you very much for coming. And so tell us about the latest updates on the use of device therapy in patients with heart failure.
Okay, thank you. So first I apologize to everyone for coming late. I had an accident today in the morning. My bag was snatched, in which my mobile and everything was there. So in the market area. So I was really, for a few minutes I was like shocked. Then I said, okay, let's leave everything, come here and do whatever I can do.
I think we need a round of applause for Ghazala's responsibility, that in spite of all this event, she reached here.
It's over to you, Dr. Ghazala.
Okay, so if we talk about the latest device therapy in heart failure, right now we have a lot of things coming in. But on top of everything is conduction system pacing, which is very good for people like our country, like a third world country, because in this we can actually use a dual chamber pacemaker, and then we can use the right ventricle lead to pace the conduction system, like his bundle or left bundle, and then we can decrease the dyssynchrony. That's the main reason of the heart failure. When a patient is in heart failure, you have a dyssynchrony. So you have to do things which can actually improve the dyssynchrony. Previously, we were doing CRTPs, Still, it's a class 1 indication. But if we see a CRT, in a CRT, we are pacing from LV epicardium. So the current is going from LV epicardium to the endocardium and then to the RV. So still, it is not a physiological pacing. But if we think logically and we are pacing directly to a conduction system area, it is a logical pacing. In a logical pacing, the QRS should be narrow. So if we are pacing left bundle area or conduction system area or his bundle area, so the conduction system is pacing physiologically. You have an atrial stimulus which is going down through the AV node, and then it has come down. It will be going through the conduction system, and the QRS, resulting QRS will be the narrower QRS complex. This is something which is new in the heart failure devices. Other than that, coming up, if I see about other than arrhythmia, we have mitral valve repair devices. We are having tricuspid annular reducing devices also, which are going to be coming up in the next few guidelines, and we can see how they are going to do in the future with the patients with heart failure. CRT, if you're thinking about a patient putting a CRTP or CRTD, previously it was the class 1 indication with anyone who has a left bundle branch and left bundle branch of QRS more than 150 millisecond. Irrespective of the etiology, we are putting the CRTD. Now, if we want to see that what is the etiology of the patient, so you have to do a MR for the patient, and if an MR you find there is a scarring in the area, then those patients are going to be benefit more with the CRTD. But if the patient doesn't have any scarring on the MR, then you can go for only CRTP. And ultimately what happened in Danish study, as we have already know, that these patients come down from the ICD indication to the non-ICD indication because their ejection fraction improved with the period of the time. Anything else? Any questions regarding this?
One last question, because of this time constraint.
Yes, sure.
Just tell us about what is this new thing, cardiac contractility modulator. Just little bit of.
Okay, contractility modulator is still not FDA approved. Number one, it's still not FDA approved. It's still in the investigational area in which they have patches in the LV epicardium, and they have the same device like a CRT or CRTP, which they put in subcutaneous area, and they give continuous contractility currents to improve the ejection fraction. The initial studies which are investigation are promising, but still it is an investigational area and it's not still approved.
Thank you very much. I think we end our session over here. I'm really grateful to the audience for patient listening and questioning. I am thankful to Fawad Farooq for his talk, Dr. Professor Jawaid Sial for his excellent comment, and Dr. Ghazala Irfan for all the way having odds and still make to come over here. I really thank you very much. And also the audience who was on the line, I am really grateful and thankful to them. Thank you very much.